So those sorts of things I think really, really are very striking. And it would be great for those of you who are joining to please introduce yourselves in the chat. We're going to have a couple of introductory remarks from our panel, from Sue and from Claire, and then we'd really like to open it up into a collective conversation about what is it that we're doing, what is it that we could learn. So I wonder, Claire, if I might turn to you first and just ask you, what is it, when you were just looking at those facts and figures, as somebody who's been in this area of work for such a long time, was there anything that kind of surprised you?
I think the main thing that that surprised me, Mindy, was the fact of not only are they still so high, the disparity is still so high, but actually it is increasing. The fact that we have got, the fact that with a misdiagnosis of heart attacks, we've got that women are 50% more likely to receive a wrong initial diagnosis. And we know statistics are now showing us that both men and women who initially misdiagnosed have a 70% higher chance of dying. And you're thinking, how is that, how is that the case? I mean, obviously I was struck with the same result as you, the fact that, 84% of women felt that they weren't listened to, which is, hugely concerning. But my particular area where I've sort of spent the vast majority of my professional life working is with vulnerable individuals and with regard to intersectionality. And when we're looking at learning disabilities, for example, the fact that the mortality rates are still, there's such disparity that women with a learning disability are still likely to die 27 years younger than women who don't have a learning disability. And the key thing is, and the thing that really, really frustrates me is, this isn't as a direct result of their learning disability. This is as a result of the fact that they have not received the same level of care. So, for example, with regard to cancer screening, and just sort of, looking down, and these are the statistics that we've been shared with you, that 52.5% of women with a learning disability have been screened for breast cancer, compared to 68% of women. If we look at cervical smears, that's even worse. 31.2% of eligible women with a learning disability have received surgical smear tests, in contrast to 73.2%. It's just, these are concerning, these are current figures, these are live figures at the moment. And then my final point that really, really surprises me is with regard to the Shelter have just at the end of last year released their fogged off report, which is, we really implore you to read. It's absolutely fantastic. And it says, in the last 10 years, the number of women in England who are homeless has increased by 88%. We're not going to go into the reasons for that now, but I think a lot of us probably know the reasons. But the reasons that they're really suffering and there's becoming health inequalities is because those services are still predominantly set up for men. So these are the kind of things that really pique my interest, and I'm hoping will be able to permeate throughout and lead to some discussions. And I know, Sue, you've got some very, strong thoughts and valued contributions to make as well.
So the same question to you, really. What struck you about the data? And then let's get into, so what can we do about that? What are our responses to it?
I think for me, kind of the primary one is actually that women don't feel listened to, and that's not new, and I suspect it doesn't come as a surprise. The thing for me is actually that is still an issue. So in some of my previous roles in the NHS, some 25 years ago, I was running Well Women clinics run by women for women, and when we evaluated those clinics for the women who joined us and attended, the one thing that they said they valued more than anything else was actually they felt listened to, and that was 25 years ago. And so the service we provided them, the most important bit of it was that they felt listened to. And I kind of feel that we kind of improved some things, but we've actually gone backwards in an awful lot of outcomes for women. And there may well be lots of reasons for that recently, like the issue around COVID and lockdowns, but that is there were things happening before that, which there has been exacerbated by that. So my particular interest around women's health is very much of the non-medical model and non-clinical interventions. And when I've recently kind of just done a quick survey of all my business colleagues, I run some business networks for women, asking them what's their go-to if they feel they have emotional or mental distress. And without fail, there was walking, painting, writing, connecting with nature. None of them actually mentioned anything about traditional statutory services. So I think outside of the statutory services, there's a lot that happens in voluntary and community sectors. There's a lot of informal networking for women and support groups. I think the bit that we really want to change for me personally is actually that no woman comes away from an interaction with a health professional saying that they didn't feel listened to.
Yeah, absolutely. Thank you, Sue. Thank you, Claire, for helping us get started. Can I open up to some of the colleagues who've joined us on the call to ask really for your experience? Did anything in that data set really surprise you? Or are there things that you are doing within your service or you're trying to do within your service that you feel is starting to address some of those issues?
Please feel free to unmute.
So perhaps just while you're gathering your thoughts then, Sue, I wonder if you could say a bit more about sort of some examples where you've seen a more women-centred approach and how that has changed a service.
And I think it's a women-centred approach, but it's also a holistic approach. That so often we treat a collection of symptoms by individual medical practitioners. So the sorts of services that I'm engaging with now and that I ran previously was very much it was run by women and for women. And it actually started from a holistic approach. So it not only dealt with kinds of any physical symptoms, but it also started to look at pointing people in the direction of maybe employment, training, learning new skills. So it was a place where you could come and talk. And they, from my experience now, there's a place on Wirral called Tomorrow's Women, which is very much about kind of the women of tomorrow, so young women, but also it's in an area of high disadvantage, and people can just come in, sit down, grab themselves a cup of tea or coffee, and there's somebody there to listen to them, and then start to tease out what are the sorts of things that actually are contributing to you feeling the way you do at the moment, and where can we signpost you within this centre that's going to help you do and move forward. So it might be gardening, it might be cooking, but it is very much a holistic approach. You know, I recognise, having worked in the NHS for over 25 years, they are not the sorts of services that the NHS can provide, and that's right and proper. But I think treating all people, actually, but women in particular, in a holistic way is one of the most valuable things that we can actually do. We're not just a collection of symptoms, actually seeing us as a whole. And the menopause, for instance, one of the comments that come out of the women's health strategy was actually if you're on the menopause, it affects you physically and mentally. And so having just one service that deals with a bit around hormones and then a little bit about aches and pains is not helpful. Actually having somewhere to go, the likes of the Tomorrow Women of the World, Well Woman Centres, actually would be really valuable.
Thank you, Sue. I wonder if colleagues who are joining from the NHS, who are currently with the NHS, have got any insight here. So do we think that there is an opportunity to adopt a more holistic approach within NHS settings, which are, you know, for all sorts of reasons, sometimes that can be difficult to do? Or are there examples that you know of where a more holistic approach has been or is being pursued?
Hi. I do work in the NHS, but I'm not clinical. I don't run services, so I can tell you about what I've seen. I haven't seen anything more holistic. It would be nice. I think first what we need to do is just listen to women talking as a patient. Yeah, you know, I mean, how long does it take for somebody to actually get to a gynae department? Average of 7 years or something. So that's fine once you're already in a department where people specialise in women's care. Great. But really, I think it needs to be focused more at GPs, and they're really not to blame either. They don't get the training. You know, they don't get the training in all these things that are important. They don't, you know, they don't get the training in learning disabilities. They don't get the training in breastfeeding. They don't get the training in menopause. All the things which come up aren't there. Training in people with different skin colours, it's not there. If my GP's 50, there's no way they've had a chance to look at that, because people have only started thinking about it in the past few years. So yeah, I think we've got a long way to go before we do anything holistic. And I think the extra money probably isn't there to do that. At the moment, what we need to do is train the people that are already there just to think slightly more widely. But that's me as a patient, not as anything to do with the NHS really. But I haven't seen anything.
Yeah. Thank you very much, Mould.
Thanks.
Renata.
Hi. This isn't about patients, so I don't know if it's relevant, but I've just had an email through today. We're very good at looking after our staff in Wales, and I've just had an email through today. I mean, I can't share my screen, but it's just you're invited to a Wellbeing Day, Wednesday, 30th of November. It's in the library. There's chair yoga, menopause for managers, Q&A with the Welsh translation, you know, the bilingual, you know, dual language, mindful menopause, signing for Wellbeing, blood pressure checks. You know, we're really kind of good at looking after the staff. So I just wanted to say it from a staff point of view.
Yeah. Thank you.
Can I jump? Oh, sorry. Sue, do you want to go?
No.
Well, I was just going to say we're probably going to end up saying the same thing, really, just to sort of, you know, to invite some more conversations, really, from what Renata and what Morgan said, some thoughts there that I think the first thing that I'd really like us to sort of start exploring when we are looking at when, yes, people say there's no extra money, but is it beyond the wit that we can look to actually prioritise this and start redirecting some of the money? I'm a great believer of, yeah, there's no point just getting militant and campaigning for money that isn't there, because you're hitting a brick wall. But if we're looking at the cost of what these misdiagnoses, the not listening to people, is actually costing in financial resources and human resources, then surely if we can start to redivert some of that and put some proposals, it would make good economic sense in the long run. And then really Renata's point, I think, is absolutely fantastic, but again, giving people permission to prioritize that, because we need to make sure that in organizations that if somebody's invited to a wellbeing day and mindful menopause and everything, that isn't seen as a, oh, is it on a Saturday afternoon where I can fit in? Otherwise, I've got work, so I can't go to it. I wonder how many women would be turning around saying, actually, I've got work commitments, caring commitments, so I can't go to those things. And I guess it's all very well, you know, we're all in complete agreement that we need to start listening, but we need to start creating the spaces where people feel confident to talk in the first place. So, Sue, sorry,
I think I was actually those wellbeing days for staff are fantastic, and you can see that there are starting to look at holistically kind of the health of a member of staff, because there are so many opportunities to test out new things, you know, mindful menopause, etc. And I think it's not, like you said, it's not always about more money. It may well be about redirecting perhaps some of the funding that is available, but that's going to be a challenge. But I think it's also about using what already exists. And I do feel that the whole social prescribing agenda actually is not that well known within particularly our acute services, much more familiar in primary care. although not as utilised as perhaps it could be. So a better understanding, I think, and that talks to the things that I've talked about, which, gardening, walking, physical activity, all the things that we know there is evidence that it improves physical and mental well-being. And there is investment in primary care to support GPs to be able to refer for those sorts of things. But I do sense that it's not that well known, and there is a lot of scepticism about it. But actually there is quite a significant amount of evidence that these things do work. There is a campaign at the moment called Beyond Pills, and I can circulate some of that information as well. And that's led by a series of doctors from all parts of the system who have recognised that actually the system can't do everything, but let's utilise what is already there. So perhaps it's awareness raising of what's available, and actually not necessarily just more funding. And it really doesn't take much to listen. We don't need money to listen.
Yeah.
And I think you're right, Sue, that with regard to the Beyond Pills piece, it's actually cheaper because obviously from a sort of pharmaceutical perspective, it's very expensive to be diagnosing tablets. Whereas there is evidence now that's showing that, and yes, I'm not anti-tablets where tablets are needed, but from a long-term perspective, actually just giving someone a course of treatment on these prescribed pills for say 2 weeks, a month, or whatever it may be, actually looking at lifestyles, making people feel valued, looking at all those other opportunities are really, really important, and actually their cost threshold is far lower.
Yeah, and the outcomes are quite significant as well. So I think there are things there that don't necessarily cost money, but we need to support the system to understand what those things are. And they're not alternatives, and they're not they're not kind of alternative therapies as such. They actually do complement what we would want to achieve in the system. I suppose, I guess for me as well, one of the questions is, I don't know how many people in the system are familiar with the Women's Health Strategy. It was not launched in the great big fanfare that you would expect, something that we've waited for donkey's years for. And yeah, so I'm not convinced that our services are that familiar with the Women's Health Strategy. So, and if we could just ask a quick question and put it in the chat box, perhaps, how many of you that have joined us today actually have heard of and read the Women's Health Strategy? If people wouldn't mind just popping that.
And what is your NHS Trust doing about it? Useful to hear, right? Just a couple of thoughts, really. So one is that what I observe from my own trust, and I'm sure it's true of many within the NHS system, is that it's not that people don't want to listen. It's what I observe is that people feel very overwhelmed in the services that they are working within. And this is going to sound not quite right, but there's something about, if I'm too curious, I'm going to hear things that I can't respond to because I can't respond to what I'm supposed to respond to. So I've got you in front of me and you're in my podiatry clinic, or I've got you in front of me and you're in my diabetes clinic, and I just need to, I can't even deal with my wait list as it is. So sometimes I think that sense of overwhelm can discourage that kind of listening, because if I've listened to it and I've heard it, then I feel that I'm required to respond to it. So I wonder if that's part of it. I wanted to ask you about, because Sue, something that you said earlier a couple of times was services that are by women for women. And I wondered if there is something about some of our kind of medicalised approach, because our medical ranks, are particularly at consultant level, are dominated by men. And if there is something about, actually, consultants tend to take the lead in service design and service operation. So I just kind of wonder if there is something actually very important about having women in leadership roles in order to influence the design and delivery of services. Is that your experience, and is that the experience of our colleagues on the call?
Yeah, I think it is. And I can only talk from my own experience, both of delivering services for women, but actually also being a woman you know, a woman having, I went through breast cancer and went through the process. So my surgeon was male, and most of them were at the time. And I have to say, I was because I'd worked in the NHS, I kind of thought, oh, I can't, you know, when I get into this situation, I'll have all my questions, I'll do all this. As soon as I put that gown on and sat in front of a male oncologist and a male surgeon, actually everything that I knew as kind of me, having worked in the system, disappeared, and I became a patient. And I look back on that process. It's not that long ago now, but I wish I'd had the opportunity to have had a conversation with a female surgeon, and there was one, but there was no choice there. Now, I'm not saying you have to be female to understand issues around women, but I do think there are certain things around women's health where the option to speak to somebody who is female or female designed services is actually really important, very, very important. So I kind of talk as a health professional here, but I also, you know, and we're all, you know, professionals, but we're also patients, and we can probably all experience, you know, talk about an experience that didn't go well. And it's not to decry, you know, my male surgeon. He was very good. He just didn't get it. And one of my comments back to him at one point was, from somebody who has 2 nipples. So, you know, and because he just didn't understand what it felt like. So I think it is very, very important that we actually do have services and female leaders who can contribute and design services from a woman's perspective.
Which leads me on to, and sorry, Mindy, if I'm treading on your toes here, but I was just sort of mindful of that, and you've just teed it up perfectly there, Sue, is off the fobbed off report, where one of the points of some of the solutions that we can do is the importance of co-production and involving women with lived experience in developing services. I wonder whether colleagues on the call have got any positive examples that they've had of real co-production in action, where people have drawn and worked together that have resulted with some really great outcomes.
We have an uncharacteristically quiet group today. So, yeah, Claire, I wondered about do we know, I guess it's a question, are there better outcomes for women in services which are either co-produced or where there are women in leadership positions? I guess that was an interesting point of inquiry, right?
Yes, there are, and it's simply really leading on from Sue's point, is the fact that it comes from, we know the value of services being informed through lived experience, because that's how we know. And it is banal to me that a lot of other services are developing, drawing on lived experience, but with regard to women's health, that isn't happening. And the reason being is they're just the subtle nuances that are happening that people haven't. So again, sort of, you know, we're sort of, you know, this is a confidential, safe space for us all to share. You know, I've had, you know, we all have, I think, you know, had a very, you know, intimate procedure done, and yet there was a male and a female in the room during this intimate procedure, and the female made time to actually come up to my face and actually speak to me like a human being, and actually start asking me some things about, you know, and actually started to engage. And she said, you know, I know what it's like when, you know, it's very difficult if you're being asked medical questions and you're having this done. So let's build up and she made an effort to build up a rapport. And there's lots of evidence to show that people feeding back and saying, actually, these were the real positive parts. And if we could build those in. And the really interesting point is, Mindy, is that even when we are talking about a trauma-informed approach, it's not real highfalutin, you know, postdoctoral study kind of stuff. It is just the making time to make somebody feel valued, just the layout of the room, just acknowledging what it has taken somebody. I've done an awful lot of work with vulnerable individuals with regard to health, and actually realising, and one of the things that really changed was saying, actually, could we have the surgery, like the one-to-one sort of face-to-face sort of surgery, could we just have it in this place, because I need to catch 3 buses to get it at the moment, and that's and by the time I get 3 buses to do that, I've got other care commitments that it's the time isn't, you know, it just isn't there, and so I'm not going to go for that screening because of the location where it is. Is there no way where that can, you know, that we can have it in somewhere else, that we can double, you know, we can double things up? I mean, and I know that there's a lot of things. It's like at the moment, we know libraries are also doubling up as food banks and stuff, but we need to go right back, I believe, to, you know, and I was involved in working with Sure Starts and children's centres, you know, years ago in the, you know, in the late 90s, and people were saying about these one-stop shops, whereas they sort of disappeared a little bit now. And a lot of the feedback that's coming through with regard to whether that's learning disabilities, whether that's with regard to, you know, EDI, whether that's with regard to homelessness, it basically says, could you just make it as accessible and as simple as possible? And then listening to people saying, okay, what would make it as accessible and simple as possible for you then? Simple as that.
There is something, isn't there, about kind of very often, you know, because what we are responding to, particularly in the health service, is a particular thing, a particular condition, a particular health condition that we're responding to. And so very often what we start with is, what are the medical requirements to meet the needs of that condition, rather than starting from what is the life of the person who has this condition, and trying to understand where it fits into their lives, what their bus routes are, what their work patterns are, what their other responsibilities are, so that when we're designing a service, we're designing it so that they can, in the very first place, access it, given the pattern of their lives. You know, before we even get onto making sure that the outcomes for them are as good as they are for men or for people at other times of their lives.
Can I, Mind? Yeah, I'm just looking at the chat, and Morgan's made a very valid point about that GPs have around 7 minutes with their patients. Morgan, were you commenting on that in relation to the social prescribing agenda?
Well, not really, but it's sort of, I've got a few thoughts. It's like,
okay,
oh, but it doesn't cost money to spend time. Well, it does. And sadly, I work in the finance department, or I'm an adjunct to it. Everything you do costs money, particularly if it's time. But what Claire sort of said, which I thought was quite good, was somebody just coming up, just changing their approach. That doesn't take any more time, because those 2 people are in the room anyway. And I'm wondering as well if we could have some kind of like a list of all of the barriers that people will automatically say, and I'm very guilty of it. Well, there's not enough money, there's not this, there's not that. And actually to just go, well, you're right, but you could do this, or you've already got to have statutory mandatory training. Could this little bit extra be added to it? You know, just ways around, because there are so many barriers to providing an awful lot of this. And we saw in COVID, if you throw money at things, it's there. The NHS is absolutely fantastic, particularly in any emergency. If you just say what you need to do and fund it, it'll happen and they'll do it. But we're not at that point now. So it's maybe getting people to think just that little bit differently, and appreciate and recognise and have it at the forefront that practically all research is by and for men. Even if it's by women, it's for men. You know, it's only very recently they've started thinking about women at all. You know, and most men cannot appreciate, and a lot of women actually cannot appreciate, those systemic issues which stop things happening. Because women have also we've been brought up in this particular environment to expect it. So unless you really challenge people, they don't think around the issue, I think.
Well, our default human is the man human, right? And that's true for all of us, because that is how we've been educated in the world in which we live. So the research person is a man person. So there's a lot to overcome there, isn't there?
Even language.
Oh, sorry.
It's human, isn't it? You know, it's absolutely everything. And I don't want to be trite about it and take it that, but it actually, that doesn't help. Yeah.
Indeed.
Can I?
Oh, sorry.
No, it's okay. Thanks for that, Morgan. I mean, when the women's health strategy, if you, I mean, I would suggest you familiarise yourselves with it, but perhaps only the executive summary. The bit that I found the most interesting, and I think might help shape kind of how that we do things differently, is actually the women's voices. And so if you read the Let's Talk About It survey, the results from the focus groups, they're women's voices, and they're women's voices both from the service and from service users across a kind of a vast array of ages as well. So I think if we're going to learn anything, actually, we will learn it from that bit of the strategy, not from the strategy itself. And the strategy itself is a 10-year ambition. And it, you know, I could say a lot about it, but anyway, I probably won't at this stage. But it is only a 10-year ambition, and they're not going to start to measure outputs or outcomes for the next 3 years. So if we wait for a strategy to do anything, actually, we're not going to get anywhere. And I am a firm believer, actually, that kinds of women, when women put their minds to something to make a change and a difference, actually it tends to happen. So I would suggest familiarising yourself with the strategy. I don't think it's going to be something that lands on your desk and there's going to be an edict from high that you've got to do it. But I think listening to the women's voices about the feedback about what they're looking for is probably one of the most important things you could do if you work in health or social care. So I would urge you to kind of to read that. So thanks, Morgan, for your contribution. Then it was really helpful to pick that back up again. Thank you.
Great. Any questions or further reflections from colleagues who've joined the call? So one of the things I wondered about, actually, Renata, just picking up on what you talked about earlier, and I know this was also echoed by Morgan, which was just about the fact that actually in terms of how we are learning to look after our staff, particularly within the NHS. So we also, in my trust, have really tried to develop the wellbeing offer and making sure that the people who care are cared for. And I wonder if there is both a kind of opportunity and a risk as we get better at doing that for our own people. So the risk might be that the gap between the holistic approach that we take with our staff versus the sometimes not very holistic approach that we take with our patients becomes more difficult for the general public to tolerate. That's good enough for you, but this is good enough for me. So I wonder if that's a potential risk. But also if there's an opportunity that if we experience ourselves the impact of a truly holistic approach to my well-being as a member of the team, if that becomes easier for me to then incorporate into my practice and into the way that I think about design of services. What do you think? I'm going to invite you back in, Renata, just because you mentioned about how good the wellbeing offer was from your trust. Oh, maybe she's just dived off for a minute. So Claire, I don't know, what do you think?
Yes, yeah, well, and hopefully Renata will come back and join us. I think that you are quite right. It's about what we want to do is actually embed it in good practice, and there is research shows there's a direct correlation between the well-being and emotional intelligence of staff, employees, and how they treat the individuals that they support. Those individuals, there's firm research there. I did a part of my PhD study actually way back in 1997 actually touched on that direct correlation, and it's just grown and grown and grown since. And says that and I'll use the word patient experience, the patient experience is improved if the person delivering the care has a good quality experience themselves. And so that is, you know, that isn't disputable now, and that comes through, and there's a rich vein of evidence that's coming through the NHS immediately. That's research that's hot off the press now. And it's also very apparent if we extend that to social care with individuals, okay, because obviously the other dip, because we saw a dip during COVID, when the individuals that were providing the care, their well-being was low, and they felt depleted, and that had ramifications for the individuals that they were supported. So what we need to start doing is, yes, we need to boost it, but rather than just, I mean, the one-off days are brilliant and it's a start, but look to say, actually, how can we just embed this into, this is good practice, let's remove gender for it from, you know, when we're having the discussion, actually treating all the individuals in your organisation, whether it's, you know, LGBTQ, you know, experiences, learning disabilities, and obviously then women and women's health issues come under that. But let's have a look about, and it'd be again interested to hear from colleagues to say, is this practice beginning to be embedded in your policies and therefore coming down through the processes and actually reaching the people? Because that's when we can see some real change differences. And it won't be then, because my concern is you can sometimes get a really, really wonderful person. You can have somebody like Sue in the room, which is fantastic. But then when Sue moves on to another job, it all falls apart. So we've got to look at ways that embedded. So I'd be really curious to see whether people feel that there is a move to embedding this in their policies and it's becoming evident through the processes.
What do people think of, for our NHS colleagues on the call?
So there's a comment in the chat. It says, as doctors in training, the support for women's health, particularly parenthood and pregnancy, has to be improved. We are hoping to work with OCC Health to produce guidance and support for staff who needs extra support, breaks, adjustments and risk assessments.
Thank you, Caillou. Do you want to, I don't know if you're able to come off mute and join the conversation, because it'd be really interesting to understand that a bit better. Because I certainly hear quite a lot from female medics that is not always what happens.
Yeah, thank you. Just managed to put on my mic. My name is Kat, one of the, I'm a registrar in medicine and also chief registrar at St. Thomas's. So one of the feedback we've got from our kind of cohort is that we're usually kind of female in kind of ranging from kind of like early 20s to kind of late 30s. And so a lot of the kind of issues that we have is kind of surrounding things like parenthood and pregnancy. I've had friends who have to kind of work through kind of quite bad hyperemesis without kind of much adjustment. There's often very kind of limited guidance into when you can actually take off. Actually, in COVID, it was quite good because it was very clear cut from higher up that actually you can't have clinical duty from 28 weeks so that you can shield. But I think now we're kind of moving into the next phase of pandemic, and this has become blurred again. And I've had colleagues who tell me that actually they're quite fearful. There's not much guidance into what they do. And I think sometimes their physical health and kind of their psychological support is sometimes it's not really there.
Yeah. That's interesting that it's deteriorated since COVID, isn't it? That that lack of clarity as we try to normalise, even though the risk is still there, particularly for some groups. And I saw, Astrid, that also resonates for you. Do you want to jump off mute and just add a bit more?
Yeah, sure. I was thinking along similar lines to the kind of hard lines they had during COVID of 28 weeks you shield, whereas you know, for a lot of our specialties, they don't have a sort of guidance around pregnancy and when it's really not appropriate for you know, somebody in the third trimester to be doing on calls, night shifts, things like that. And it's very much down to the individual trying to advocate for themselves, which is obviously a sensitive, you know, time, and you're also aware that you're leaving the workplace you know, imminently, and you're wanting to sort of pull your weight, but yeah, I feel like often there's not a lot of support at tailoring the you know, the plan to suit the individual, and it's you know, very much, oh well, if you're fit to work, then you should be doing what everybody else is doing, which can sometimes feel a bit, you know, really unfair.
Yeah, and unrealistic. You know,
Yeah, absolutely. Yeah.
those of us who've gone through the trimester, it's not it's just unrealistic.
Yeah.
And so do you think would it be improved if each trust, or if there was indeed an NHS policy on that?
I think it would. I think if there was this kind of starting framework to even have some of these conversations, because often it feels like it's not really broached even at all. And I know, you know, in my personal situation, it was often me that was having to sort of sit down and say, hello, everybody, I'm going to be 28 weeks soon and therefore won't be patient facing. Whereas I think if there was something just to guide, you know, kind of clinical supervisors or managers about the sorts of conversations that should be taking place during that time, that would be a start, really, because it's a bit like the elephant in the room and the onus is on the individual a lot of the time.
Mindy, can I just, the women's health strategy, the really positive thing about it from kind of my perspective is actually it does take a life course approach. So it actually deals with women's health right from kinds of puberty and periods right through to kind of towards the end of life, but menopause and all the stuff that comes with age. But there is a big section in that strategy around the workplace. Now, I can't remember from memory whether or not it covers pregnancy in the workplace, but I'd be surprised if it didn't. But it is only a strategy for England, as somebody pointed out before. But I think there are things in there that you can take wherever you're from across the UK and actually see whether you can do anything with that from your trust's perspective or from your system's perspective. So taking a life course approach includes then pregnancy and right through to, as I say, to menopause and post-menopause, and a big section on the workplace. I know that for me, the workplace seems to have been taken over a bit by the menopause discussion, and rightly so, and it's not a criticism, but there are lots of other things around women's health which are pertinent to the workplace. And not least of which, as we have a much older workforce and it's much older women in the workforce, that we actually have a lot of caring responsibilities. And we may not be a formal carer, but informally we have elderly relatives for which we have caring responsibilities for. So like you have issues around creche and access to childcare in the early stages of career, I think we're going to find a system that actually has got an awful lot of pressure on the staff, particularly women who have caring responsibilities. And how do you retain those staff for their skills and experience, but allow them to have those caring responsibilities as well? So I think, have a look at the section around the workplace and see whether there's anything in there around pregnancy that might help you form your discussions.
And I think just carrying on from that, I know we've got some statistics on that over 6.5 million unpaid carers in the UK are there's over 6.5 and the majority of those are women, and we know that it's increasing. And then actually what that leads that they're saying that women aged 45 to 54 are twice as likely than other carers to actually lead to having reduced hours, because they just can't manage all of everything on top of their caring responsibilities. But just winding back up to, so am I hearing it? And from what, leading on from what Sue said and from Astrid and Carl, that is sort of saying about we need to move it even further back from the policies to actually embed some of this stuff in the basic training right from the get-go. So people, when they're coming into professions, this is forming part of their training. And I'm not saying that those that are in it don't need refresher training as we're going in, but we need to look at, if we are looking at solutions, saying, well, actually, how can we inform what initial training is taking place for people and how often that is being refreshed?
For those of you who are current in, Carl, I was wondering for you and for you, Astrid, do you recall having that training? Because you're through the system you know, were you trained in that, and do you get refresher training in that, in those sorts of listening skills and so on?
I guess not in a very particularly prescribed way. And I guess a lot of it is as kind of junior doctor, I think as a chief registrar, you have a bit more kind of power in the way to shape like how junior doctors are supported, etc. But I think I'm talking about the training as a whole, as in a very diverse kind of workforce. I think it's very I think a lot of the junior registers you kind of have to learn at the get-go, and then it's particularly into kind of women health, etc. It's not really very prescribed in the curriculum. So I'm a general medic and I work with older people mostly. And then only today, when I was looking at the women's health strategy, did I realize that actually a woman are disproportionately affected by dementia, not just because of their prevalence, but also because they're more likely to be carers. They're twice more as likely to be carers for someone with dementia. So I guess sometimes in our curriculum, in our training, we actually don't really acknowledge that disparity quite well. And I think that's something to kind of bear in mind and that we can reflect on ourselves.
That's fascinating, isn't it?
Mm.
What about for you, Astrid? Is that the same for you?
Yeah, similar. The role I'm doing this year is because I'm doing sort of a out of program similar sort of role. I've had a bit more time and space to kind of think about health inequalities in general, and I've had time to read up on some of this, but I don't think it's very well embedded into our clinical training, certainly at a postgraduate level, I would say. I think a lot of the focus is on clearly sort of clinical diseases rather than more sort of holistic. I can see lots of nodding, so that's probably similar to others' experiences, but it's the holistic focus, I would say, isn't really there in the same way.
Yeah, that is really striking, isn't it? And also I just kind of wonder about the, not in ways of not placing the medical condition within a social context. So, knowing that more women are affected by dementia and more women carers, actually that's a really important kind of part of the social context, isn't it? In terms of being able to understand it, but it's not what we're focusing on. We're focusing on the medical treatment of the disease.
I mean, there were some stats that I pulled out around antidepressants yesterday, because this has been a key thing of mine over the last couple of years, about kind of the number of women who are prescribed antidepressants as a first course of action without really understanding the issue. And the data proves that women are around twice as likely to be prescribed antidepressants as men. And the figures also show there's a significant gap between rich and poor, with 17% of the nation's poorest needing antidepressants to cope. Now, that's not my words, but that's come from the data. So I think there is a whole issue, and also there's a marked increase when you get to the 45 to 60 age group in women. And that's predominantly when women are going through perimenopause or menopause, and often a first line of treatment is antidepressants. So that's not surprising. But I think there is a whole discussion around and it plays back into the Beyond Pills campaign. That's not just about antidepressants, but I think as we've come out of COVID and lockdown, we've seen the numbers of antidepressants prescribed soaring, with access to talking therapies reduced. So actually, I think we are setting ourselves up for a huge issue over the next couple of years in the systems, both health and social care, around people who have been on antidepressants for quite a substantial amount of time without really getting to the bottom of actually what the cause is of those issues. So yeah, that's quite a worrying, and not just that, but the cost of prescribing antidepressants is huge. So I think, there are issues that we perhaps need to look at specifically around the prescribing of antidepressants for women.
Yeah. I mean, it does feel, doesn't it, that given the funding constraints and given the huge increase in need, in all sorts of, both in physical need and in mental health needs during the course of the pandemic, that we are struggling just to, keep sticking plasters over what's erupting right now, and that what we're doing is storing up really very, very difficult, and perhaps making it truly intractable time. John.
Thank you, Mindy. I've been interested to listen to what people have been saying. I just wonder, as we reach the sort of end of the time, whether the group and the panelists feel there's anything that the Institute could be doing in this regard, building on the women's health strategy. Just to ask the group, kind of, it's not so what, it's so what do we do now to try to improve matters? Is there anything that the group feel that the Institute could do to support this initiative? Thank you.
It's a great question. Should we throw it open to our colleagues who've joined us on the call? What would you like to see? Morgan? A document which lists the barriers and ways around it. Yeah. And is that the barriers to understanding and implementing the recommendations of the Women's Health Strategy? Or are you thinking more broadly?
Or just anything that we want to do. Also, if we could have some kind of chat, I mean, the whole sort of mental health side of it, I think there are many reasons why women would be given antidepressants over men, partly because they talk more, etc. So it's not as simple as that. And I just wonder if it would be quite interesting to have a sort of a mental health professional come on and just talk about stuff in relation to women. I think that would be really interesting, actually. I think Sue's brought up some really good points. And if we want to look at things holistically, then we probably do need to understand that as well. I think it'd be really, really good. Just specifically from a women's point of view, that would be great.
Thanks, Morgan.
Thank you. And perhaps I might ask Sue and Claire if you have some initial thoughts in response to John's question. So
well, I'll go first, and I'll let Sue finish, because Sue, you let it. So it's appropriate that you kind of have the final word really on this. My view is, actually, we've started, John, in response to you, I think we started the ball rolling, that like Sue waved the flag today and said, actually, who has seen this? And it's glad that actually not many people have. So the Institute have already started today, but we've flushed it out and put it in the light. I think then the next step is, let's see how we can break that document down, as make it as accessible to individuals, and maybe deliver through, and I hate to use this phrase, but everybody knows what I mean, through kind of bite-sized chunks. You know, let's do a spotlight on each of the key areas that we can say, let's do some sessions about breaking it down, because, you know, this is why I wanted to jump in ahead of Sue, because Sue can probably direct our thinking to say, actually, a good place to start, because Sue already said, well, let's start with the executive summary, but then beyond that, let's have a working group then to go away and let's go away, read the executive summary, and then come back and say which bits of that would be really useful for the Institute to run a session on like this, so we can have a real interactive exchange. Sue, over to you for final comments on it.
Oh, thank you very much. Yeah, I think, John, thank you for the question. I think the Institute can have a huge role to play. I think breaking down the strategy into kind of the bite-sized chunks is really helpful. I think definitely something on kinds of mental health and well-being of women, and particularly linked to the prescribing of antidepressants. I'd also think if we could get the Institute perhaps to get somebody from the working group that actually set up this women's health strategy. I know we have a women's health ambassador. My fear, I have to say, is that because of all the changes in government and because of everything else that's gone on, that actually it won't be kicked into the long grass, but it won't be talked about very much either. So I think if we could get somebody to come and actually tell us what's happening around this now, how can we as an institute play into where it is now? This is not an end document to me, it's a beginning of a conversation, and I would like us to be able to influence the process going forward. Otherwise, I fear it will just be left. You know, that it's a 10-year ambition. That worries me when it says it's an ambition, because it implies that it might not be met. It's what we'd like to do, but we might not do it. And I'd like to hear from kinds of women leaders in the system. What can we do to help? What would help you, both as a woman's leader and having health issues, but also to help make your services more appropriate, and so women don't walk away feeling that they've not been listened to. I think if we could do something to change that, we'll have done an awful lot.
Great. Thank you for those early thoughts. That's given us a lot to think about how we might work together with the Institute to do that. In our final minute, I just wanted to really thank both you, Sue, and you, Claire, for being our panellists today and to helping the conversation really sort of broaden out into a rich discussion. And I really want to thank all of you who've joined, giving up an hour of your day to come and think about this. I'd like to give the final word to Jade to talk about our next event, which we're extremely excited about. I want to make sure that those of you who can join us, make sure you get your hats in the ring to be with us. So over to you, Jade. You're on mute.
It was bound to happen at some point, wasn't it? Thank you so much, Mindy. Thank you, Sue. Thank you, Claire, for a fabulous discussion. Yes, our next planned event is a physical one in London. We will be interviewing Dame Claire Gerarda, who's president of the Royal College of General Practitioners, on the 2nd of February, 12 till 1. We are limited to 20 places, so if you'd like to attend, please drop me an email so I can keep track of who would like to attend and offer tickets as they become available if there's a waiting list. We are dead on 1 o'clock. Thank you so much for everybody attending today. We have recorded, so if anybody would like to catch up if they've missed anything, or for those that are catching up now, then please do email me if you'd like to attend the Dame Claire Gerarda interview on the 2nd of February. But that's all for today. Thank you so much, everyone. We look forward to seeing you again soon. Take care and enjoy the rest of your week. Bye.
Thanks.
Bye.
Bye. Bye.